Good morning, everyone. I welcome all the faculties and delegates for this session. The first session will be, the first talk will be screening for preeclampsia in first trimester.
This talk will be delivered by Dr. Kamlapurkar. She is an extremely accomplished lady, and it's a pleasure for me to introduce her because she is absolute favorite of mine. She has got a very long list of accomplishments, but personally what I have appreciated about her is extreme enthusiasm, dedication, precision, perfection in her work, and she demands the same from other people also. That makes her best, and her good, like she's keenly interested in field of not just high risk obstetrics but fetal medicine also, and she has presented fetal medicine papers in international conferences in fetal medicine forums. So we are extremely lucky to have her today. Over to you, ma'am. Thank you so much.
Thank you.
A little more introduction. In obstetric, she's in obstetric practice since last 20 years. She's chairman fetal medicine and genetics committee Kasoga. Founder, President, ISOPAP, Kalburgi chapter.
It's
she has
okay.
been faculty in many conferences.
Good morning, everyone. Respected Melincha sir, Rohini Deshpande ma'am, the office bearers of Solapur OBGYN Society, and delegates. At the outset, I would like to thank Solapur OBGYN Society for having me invited for just sharing and giving me an opportunity to look into the same subject again and again. This talk I dedicate to Professor Chris Redman, who has recently passed on August 13, 2024. And the Lancet says about him that today's success in dealing with preeclampsia reflect a better understanding of its underlying processes. Much of it is derived from Redman's own research. When we go through the references on preeclampsia, majority of the references are in the name of Professor Chris Redman. So why should we worry about preeclampsia? I did not go in details, but a few important points I would like to discuss. That preeclampsia, as we all know, that May month is celebrated all over the world as Preeclampsia Awareness Month. And every 7 minutes, a woman dies due to preeclampsia. Globally, 76,000 women die each year because of preeclampsia. And 5 lakh babies die each year because of preeclampsia through prematurity, which can be preventable. And in India, preeclampsia affects about 10.3% pregnancies. How it affects the mother? It has been shown that these mothers who have preeclampsia in their pregnancies, they have very high risk for cardiovascular diseases, hypertension, stroke, renal impairments, metabolic syndrome, and diabetes later in their life. The life expectancy of a woman who develops preeclampsia during pregnancy is reduced on an average by 10 years. And that is the reason we need to prevent this preventable disease. And I will be dealing with first trimester screening of preeclampsia. And of course, pregnancy is the vascular stress test that each woman undergoes to assign her risk for developing these cardiovascular complications later in her life. For baby, there are short-term complications and long-term complications like fetal growth restriction, oligohydramnios, IUFDs, preterm birth, low Apgar score, non-reassuring fetal heart rate during labor and need for NICU admission, whereas the late complications for the baby are cerebral palsy, low IQ, hearing loss, visual impairment, so on and so forth. The thing is that all these are preventable if we take due care, and we can see that this can be preterm preeclampsia before 32 weeks can be 100% prevented if we offer them thorough screening. We know that there are various definitions about preterm preeclampsia, like traditional definitions where hypertension plus all these factors. But this International Society for Study of Hypertensive Disease in Pregnancy adds one more factor with hypertension as fetal death or fetal growth restriction at the time of the screening. How do we classify preeclampsia? These can be classified as early onset preeclampsia with delivery less than 34 weeks of gestation, or late onset when delivery is more than 34. It's also said that preterm preeclampsia when delivery is less than 37 weeks of gestation, and term eclampsia when the delivery is beyond 37 weeks. There are traditional risk scoring systems which we know that NHS or NICE guidelines give high risk factors and moderate risk factors. So we all know these high risk factors. If one high risk factor is present or two moderate factors are present, then we call this woman as a high risk patient, and she needs to be given aspirin prophylaxis. ACOG guidelines also gives high risk factors and high risk and moderate risk factors. But if we stick only to this protocol, the detection rate will be only 40%. We have HDP Justice score from FOXY, and it's very easy also to follow. Here also there are 3 factors and 3 grades we have been given, 1, 2 and 3, high risk factors, moderate and low risk. And total score we have to calculate. We have to personally ask these questions to the pregnant lady, or we have to train our staff to ask the questions to that patient and then collect the score. If the score is more than 3, the woman is at the risk of developing hypertensive disease of the pregnancy, and we have to mark this on our ANC or OPD paper and the Justice score. But Fetal Medicine Foundation uses Bayes theorem for combined risk. We know for down screening, maternal age was the first screening factor, and then various screening factors were added to that. Then came NT was added, then came biochemistry, and then the detection rate jumped to 90%. The same way we can follow for preeclampsia, where we have to determine prior or a prior risk by maternal characteristics, her obstetrics or medical history, and then add biomarkers to modify her a prior risk to have new estimated risk. How this can be done? What are the biophysical markers? The biophysical markers are mean arterial pressure and uterine artery PI, whereas biochemical markers are PLGF, S-flake or endoglyne. So before we understand what are the biomarkers, it's very interesting to know pathophysiology of this 2-stage model which was recommended by Professor Redman. And here we can see that syncytial trophoblast stress in preeclampsia, and this is the convergent point for multiple pathways. The early onset preeclampsia will have the placentation pathology, and then that will lead to syncytial trophoblastic stress, whereas late onset preeclampsia, what will happen, there will not be space for the villi to grow in a limited space, and that he described this as a pot-bound placenta, where in a pot, the roots are growing and growing in the constrained space of that pot, and that is the same pathology which has been described for late onset preeclampsia. It was initially thought that the maternal factors contribute more to the late onset preeclampsia than the early onset preeclampsia, but the recent evidence says that they are equally responsible for having inflammatory factors for stage 1 by pre-activation of the maternal endothelium, and that is why we need to take the maternal factors into consideration, and that is very important. So uteroplacental malperfusion is the early onset preeclampsia reason, whereas in late preeclampsia it is the pot-bound placenta. Intervillous malperfusion is the etiology. So what happens? So as the pregnancy advances, the growth of the placental villi will increase, whereas the distance between the villi will decrease and there will be crowding leading to this pot-bound placenta. So PLGF and S-fleet, these are the biomarkers for sensitive trophoblast stress. We can see that from 13 weeks to 40 weeks, the levels of PLGF rise, and from 32 weeks they fall, whereas S-fleet levels are at plateau till 20-24 weeks, and they start rising from 28 to 29 weeks onwards. And that is the reason S-fleet is not useful for first trimester screening, whereas PLGF is. So Professor Chris Redman has described this placenta as twilight placenta, where the placenta is old, it is hypoxically stressed, it's losing its function, and therefore there is increasing S-fleet and reducing PLGF levels. This placenta is struggling to sustain a growing fetus which competes for the space as well as oxygen. So what happens first? Is it the delivery or a problem? So they have come up with the competing odds model for screening of preeclampsia, which describes that if we allow a woman to cross 40 weeks of pregnancy and reach 50 weeks, 60 weeks, then all women will have preeclampsia. But what happens in high-risk cases, the preeclampsia occurs much before this deadline of delivery. So finishing line or deadline is the delivery, and the preeclampsia occurs before that. How is this important? It is important because it gives us the personalized risk for a single woman. Preeclampsia, it can give at a risk at any desired gestation. A woman can have the risk at 24 weeks, 32 weeks, 40 weeks and beyond. It can be easily expanded to include the additional biomarkers which are measured at any gestational age. So with this, we are now following FMF preeclampsia triple test. But this triple test, we have to just be sure that it's quite different from the triple test what we used to do in down screening. In preeclampsia triple test, the three factors are clinical parameters like medical history, maternal characteristics, pregnancy characteristics, and maternal mean arterial pressure. The second factor is uterine Doppler, mean uterine artery PI or pulsatility index, and addition of biomarker, that is PLGF concentration. So uterine artery Doppler will give us the idea about the defective trophoblastic invasion, whereas the biomarker PLGF will give us an assessment for hypoperfused placenta and pro-inflammatory proteins, and clinical parameters will give us the cardiovascular maladaptation that lady is having because of the disease. So this is this pre-study where they have compared the NICE guidelines and FMF triple test. So if we follow only NICE guidelines, the detection rate will be around 47% for preterm preeclampsia before 34 weeks, or 41% for 37 weeks, or 26% for more than 37 weeks. But if we follow the FMF triple test protocol, then the detection rate will go to 90 to 100%, almost 100%. So almost double. So NHS guidelines or NICE guidelines are not enough. We need to add this FMF triple test to that to increase our detection rates. Here we can see that maternal factors, mean arterial pressure and uterine PI for gestational age of 32 weeks preeclampsia, detection rate is 83%. And if we go on adding PLGF, then it will be just 79%. But if we add maternal factors, MAP, uterine P and PLGF, it reaches to 90% for preterm preeclampsia, whereas for late, of course, for preeclampsias more than 34 weeks, the detection rate is less. So the prediction of preeclampsia, the risk factors plus positive, but triple test is negative. I mean, the maternal factors, history is there, nice guidelines, the woman is high risk, but if we add triple test, the risk can change. As we see for the Downs, maternal age is 30 years, and if we do, and if she is high risk as per the, her age, the risk is more, and if we add other parameters, the risk will come down. The same way here, we can see that ACOG guidelines or NICE guidelines are positive, and FMF triple test is also positive, then it will be 4.8%. But ACOG guidelines, the woman is high risk, but FMF triple test is negative, the risk will drop to just 0.25%. And same is with the NICE guideline. So NICE guidelines or ACOG guidelines or Justice Code alone will not be helpful. We need to incorporate the triple test of FMF. Here we can see that if we add PAP-A, we used to say that PAP-A is also a good marker for screening of preeclampsia, but the sensitivity is less, and we can see here the detection rate is 83%. And if we delete PAP and if we add PLGF, then detection rate is 90. So PAP-A is not very efficient for screening of preeclampsia, whereas PLGF is. So this is the FIGO, which is now FIGO guidelines, which are now recommending a pragmatic guide for first trimester screening and prevention of preeclampsia. This is the FMF protocol, where we can see the risk assessment inverted triangle care of the prenatal care, where we see the woman at 11 to 13 weeks, then stratify her risk, low risk or high risk. If she is in low risk group, reassess her risk of preeclampsia at 20 weeks. But if she comes in high risk group, we can offer her aspirin as a preventive protocol. The FIGO also recommends the same thing. Here also they are considering the maternal factors, and then combined risk assessment is given. And if screen low, what we call it as a 1 in 100, then routine prenatal care is offered. Whereas if she comes under high risk category, that is more than 1 in 100, then we offer her aspirin. So FMF protocol, here we can see from 12 weeks screening, then 22 weeks, 32 weeks, and even at 36 weeks. So all these are there. S-fleet, here we can see it will be useful only beyond 22 weeks, because it takes time for the pathology to develop and then fall the levels of PLGF and increase the levels of S-fleet. So this is useful for second trimester screening and onwards, whereas it's not useful for first trimester screening. And this is the ophthalmic artery ratio, which is upcoming marker, and it's very easy, better, even easier than uterine artery. So your ophthalmic artery ratio, I'll come to that, is useful in all the 4 steps of preeclampsia screening. Coming to mean arterial pressure at 11 to 13 weeks, we need to know that mean arterial pressure can be now, we can get lot of apps which are there available on the mobiles. We need to just have her automated blood pressure and calculate systolic plus systolic blood pressure, and then with this formula we can take mean arterial pressure. Why this is important? Because the mean arterial pressure is better predictor for preeclampsia than only systolic or diastolic blood pressure or an increased blood pressure, because it's a better indicator for organ perfusion of the vital organs. How it can be calculated? We need to see that the protocol has to be followed. We need to see that the woman comes to the OPD, rests for 5 to 10 minutes, and then we check her blood pressure. So back should be supported, leg should be supported, then arm should be at the level of the heart, and we can have these tables. These are available. We can just have this type of table, order from Amazon, and it's there, and we have to have 2 readings at a time, and then just calculate the mean of the 2. I understand it's a little difficult in practice, but for precise mean arterial pressure and precise risk screening, we need to follow the protocol. So validated automated devices are must. Women should rest for 5 minutes, and then we should check various cuff sizes. We should just educate our paramedical staff to use the cuff sizes properly, and then go for mean arterial pressure. Coming to uterine artery Doppler, almost everybody is doing now uterine artery Doppler. How to record that? That also we know. Machine settings will be just color Doppler velocity. It should be 30 to 40 centimeters per second. Pulse wave Doppler velocity should be 80 to 100, and we need to have low filter and pulse Doppler sample volume of just 2 millimeter to cover the vessel. So we just have to go to the parallel to anterior superior iliac spine, then just tilt our probe, come to medial side, just have the crossing of the iliac vessels, and then start color and put the sample and get the flow. So when we see that when we add uterine artery PI to these 2 factors, the detection rate increases to 83%. So all of us should be trained for doing uterine artery Dopplers during NT scan. This is one of the other technique for having, if we have difficulty in having uterine artery Doppler in sagittal, there is one way, novel way for transverse technique where we can see So we can start with a sagittal view, and then video nahi hona kya hai? And then just rotate the transducer 90 degree, make it transverse, and then see. So initially the transducer is vertical sagittal, and then you just see come to the level of internal os, and then rotate the transducer at 90 degree. We get the, here we can see the cervix just below the bladder, and we can see 2 uterine arteries on either side. It's very easy method actually. We can do both at a time, and then we can put the sample and have the uterine artery. So this is a novel transverse approach for the measurement of the uterine artery PI, which is very easy also. You can just go and practice. Start with sagittal, come to the level of internal os, then rotate the transducer at 90 degree, and just go to the right and to the left. But at the level of cervix, we can get both the arteries, uterine arteries, in the same plane. Coming to PLGF, which is the member of the family of angiogenic growth factors, it stimulates the trophoblastic growth, and low levels are of course suggestive for defective placentation, and the levels of this are much more earlier than the proper manifestation of the disease. That means 9 to 10, 11 weeks before the clinically manifestation of the disease, we can detect the low levels of the PLGF. Here we can see that when we do the comparison for PAP-A and PLGF, see PAP-A is in blue, see the detection rate remains same, whereas when we add PLGF, the detection rate goes high. So PLGF is of course a better marker and not much costly. We are anyway asking for down screening double marker. We can ask it The lab costs about 1500, it seems, 1200 to 1500 extra for this PLJ, but it will give us an immensely informative assessment. So then we'll have this type of report where they will give the risk as the early preeclampsia risk before 34 weeks, preeclampsia risk before 37. Here it is 1 in 84, here it is the risk before 37 weeks is 1 in 27, and fetal growth restriction risk also will be given. So this is useful, and 1 in 100 is the cutoff for this PLGFs. So why do we need to this screening for all the women? It's very important because we need to, there is a scope for us to prevent the disease and improve the obstetric outcome. And we all know about the aspirin study, where the aspirin is started at 12 weeks and it should be stopped at 36 weeks. We all know that the dose of aspirin is 150 milligram per day, that is 2.5 to 3 milligram per kg body weight. But the aspirin, there were in between various studies, can we have 75, 81 milligrams, but the aspirin resistance is about 30% if we give, this is 81 milligram, and whereas the aspirin resistance is just 5% if we give the complete dose of 150 milligram. So that is the reason why we give 150 milligram. So what happens with the aspirin? When we give aspirin for preterm preeclampsia, there is 89% reduction in preterm preeclampsia. Before 37 weeks, the eclampsia reduction will be 62%. Timer?
Yes, ma'am.
Okay. And after 37 weeks, can I have 5 minutes more?
Yes, ma'am, and that ophthalmic artery, something about that.
And the reduction rate will be less when we compare it for 37 weeks. So aspirin trial shows that the prevention of preeclampsia, aspirin will not completely stop, whereas it will delay the process. Here we can see the eclampsia is delayed. The onset of the disease is delayed with the aspirin. And we should never start aspirin after 16 weeks because it has got considerable side effects like GI bleed and intracranial bleed. And there is a concern about the fetal defects, but they are not much as with the placebo. So we need not worry. Should we recommend aspirin for all irrespective of the screening? It should not be because of the side effects of the aspirin. So this is ophthalmic artery Doppler, which is very simple. We can use, this is a 9L probe. We can even use transvaginal probe. I have tried that. So a transvaginal probe also can be useful. We have to do this ophthalmic artery. Then here see, here is the eyeball. We see the optic nerve. The hypoechoic line will be seen as, and that is the optic nerve. And just besides that is the ophthalmic artery. We have to just take the waveform, and there will be two systolic waveforms, systolic 1 and PSV1 and PST2. Then we have to have ratio of PSV2 to PSV1, and then we have to have both right and left. So details are available. So we can just see that this is going to help us as effectively as uterine artery PI. Here we can see the detection rate with uterine artery PI is 74, whereas if we are not able to see the uterine artery, then we can try for ophthalmic artery, and then the detection rate is still equally good, that is 73%. So as an, our own data we can, or as our own learning, we can start doing ophthalmic artery Doppler, follow these patients and see what information you can gather. So this is newer concept of Lumella test being introduced under study yet, not introduced into the market, glycolated fibronectin. It's also going to be a very useful test for prediction of preeclampsia in first trimester. So universal screening, all pregnant women should be screened for preterm preeclampsia during early pregnancy by first trimester combined test with maternal risk factors, biomarkers as one-step procedure. The risk calculator is available free of charge on fetal medicine FMF website or even perinatology.com. The FIGO encourages all countries and its member association to adopt and promote strategies to ensure this. So this is FMF. When we feed all the important information which is there, then we can get the risk of the patient and recommendation also. So this is very easy. Our assistant also can do for us. They can gather all the information. What we have to do is just to give them the gestational age and uterine artery PI, and they will come out with this. We can give this, the screenshot, we can give printout to our patients. It's very easy. So I once again thank all the office bearers of Solapur Obstetric Gynec Society. माझी माहेरची सोसायटी असल्यासारखं वाटतं आणि येताना थोडं जास्तच प्रेशर येतं आणि आपल्या माहेरच्यांसमोर परफॉर्मन्स द्यायला सगळ्यात जास्त हेजिटेशन असतं. तसंच माझं काय नेहमी होतं आणि त्याच्यामुळे मला जास्त वाचायला लागतं आणि इट्स रिअली इंटरेस्टिंग फॉर मी टू गो विजिट द सेम टॉपिक अगेन अँड अगेन. आय रिस्पेक्ट दिस title of the conference, Fetus as a Patient, and lastly I would say that let's try doing ophthalmic artery Doppler and come up with our own data. Thank you so much.
Thank you so much, ma'am, for that detailed talk and the comparison you have given us between the different guidelines, and it will be definitely helpful, and we'll try to do the ophthalmic Dopplers as you have said. The questions I think we will take at the end of the session.
We request Dr. Nanda Mage madam to felicitate Dr. Megha Kamlapurkar madam. We also request Dr. Neeta Ghate madam to join the felicitation. I request Dr. Bakur Jagidar madam and Dr. Meena madam to join the felicitation. I request Dr. Milind Shah sir to join the felicitation.
Good, congratulations.
I request Dr. Milind Shah sir to felicitate our chairpersons, Dr. Meena Gunsotikar madam. Meena Gunsotikar madam.
अजून 2 टॉक. Hello. Now I call upon next speaker, Dr.Vaishali Chavan madam. She is clinical director, Cloud9 Hospital, Kalyani Nagar, Pune. She is director of Sanvi Clinic, Women's Healthcare, vice president elect Pune OBGY Society 25-26, chairperson Perinatology Committee Foxy 18 to 20. She has publications at her credit, chapters in various books, contribution to many Foxy focus, and chapters in international publications. Now, okay, inspiring gynecologist of West India by Times Group. Over to you, madam.
Good morning, everyone. Thank you, respected chairpersons, for the kind introduction. Dr. Nanda, Dr. Bakul, Dr. Meena. It's wonderful to be here on this beautiful Sunday morning, and special thanks to Dr. Milind Shah, soon to be President Foxy, and yes, thank you, sir. Thank you to Dr. Neeta Ghate, Dr. Monica, yeah, and Dr. Sumit. It's a pleasure to meet you, Dr. Prarthana, and so many office bearers, Dr. Amruta, Dr. Lalita, Dr. Jadhav, and how can I forget Madam Rohini ma'am? What a fantastic panel that was. So coming to my talk about the newer updates in antenatal corticosteroids. So I bring to you greetings from the city of Pune, and when we talk about antenatal corticosteroids, I would like to say that there is a good news, the bad, and there is ugly truth as well. And the concept is fast changing, us as students what we learned in medical college and how the concept has evolved over time, and today what actually is the truth about antenatal corticosteroids. So we all agree that it should be given between 24 to 34.6 weeks of pregnancy, and there have been many randomized RCTs which have proven time and again that the incidence and severity of respiratory distress syndrome is much less. It gets reduced with antenatal corticosteroids administration to the mother. And of course, there is a reduction in the intraventricular hemorrhage and reduction in the necrotizing enterocolitis. So we all agree with this, and this concept has been following, and there is no change about this. So we know, yes, there is a good part. Almost, we can see there is almost 64% reduction in the RDS. There's a huge reduction in the IVH, in the necrotizing enterocolitis, and also in the neonatal morbidity and mortality. So what is a bad aspect of antenatal corticosteroids? Well, there have been many RCTs which have shown that maternal administration of the steroids has led to lower birth weight in the baby. There could be neonatal hypoglycemia, and what is more worrisome is there could be behavioral psychiatric problems later on for the offspring. So there is a huge population-based cohort study, and the ugly truth today is that repeated exposure to maternal anticorticosteroids can lead to mental behavioral disorders in that particular baby, and that baby may develop deficit in the IQ. So that is the truth, and we need to know more about this. And there have been various studies, and these are very interesting studies. More than 1 lakh babies were involved in this, and they have shown when antenatal corticosteroid was given to a preterm indicated patient, and the patient delivered within 7 days of giving antenatal corticosteroids, that baby did well, the head circumference was good. But when antenatal corticosteroid is given and the patient fails to deliver and carries forward the pregnancy till term, and at term when the baby delivers, this baby has less head circumference. So it is very important to give these steroids only to indicated patients, only to patients who are preterm, who are likely to deliver within next 7 days. Indiscriminately giving antenatal corticosteroid just at the suspicion, or just because you feel she may deliver and she doesn't end up delivering and she delivers at full term, then that baby may develop lot of problems later on, not only with behavioral, psychiatric, but also reduction in the head circumference and IQ. So going back to history, antenatal corticosteroids are associated synonymous with the name of ligands. He and Hovey first reported the use of corticosteroids as early as 1972. And as we know, the pulmonary, the alveoli, the sacs, pulmonary system is one of the systems which are last to develop, and it's only when the baby is born that the lungs actually start functioning properly. So going back to the historical aspect, so this was done, it was in 1968, they used the fetal lab model, and in 1970, appearance of pulmonary surfactant in the fetal lab appeared with the administration of corticosteroids. This was discovered in 1970. And after that, there was a long gap, and it was only in 1994, after 22 years, that antenatal corticosteroids was recommended, and that is when the NIH consensus statement came that yes, when you give these steroids, there's decreased requirement for surfactant, lower oxygenation requirement, and decrease of prolonged mechanical ventilation. All these, so definitely there are beneficial effects of antenatal corticosteroids. It's also important to know when we give steroids to the mother, it is something that we are giving to the mother and we hope it's metabolized well by mother and transferred to the baby. So there's a very complex situation where how much is the clearance in the pregnant patient, how much is the placental transfer, how much steroids actually goes to the baby, and how much is the clearance in the fetus. So there is an unknown pathology here, an unknown mode of course of action of the antenatal corticosteroids. So when we talk about mechanism, we know there are type 1 pneumocyte and type 2 pneumocyte, and steroids accelerates the development of that. It's very interesting to know how the fetal lung develops. So it is said that the fetal lung appears as early as 22 to 26 weeks. After that there's division and the canalization occurs 17 to 25 weeks. It's very interesting to know that the lamellar bodies which actually store the surfactant that appears at 22 to 24 weeks. So if you are trying to salvage a baby less than 24 weeks, the lamellar bodies are not formed, there's no way of storing surfactant, and hence it is recommended that try not to salvage babies which are less than 24 weeks. And then the lung volume grows rapidly between 28 to 37 weeks, and alveolar stage of growth, of pulmonary growth keeps happening 1 to 2 years after birth. So steroids are important, they help in the lung fluid absorption after the baby is born. So we all agree, yes, there are major benefits with steroids, decrease in the neonatal death, decrease in the RDS, and decrease in IVH and NEC. And not only that, the Government of India, Ministry of Family Welfare has recommended that auxiliary nurse midwives are trained to administer antenatal corticosteroids between 24 to 34 weeks and timely referral to a higher center where beta NICU care is available. So it's important to know the timing of giving these steroids, and it should be time that maximum efficacy can be achieved. Sometimes we don't have enough time. Even if you give one dose and patient delivers within 3 to 4 hours, even that is better than not giving any steroids at all. Coming to the choice of drugs, there's a lot of discussion which is better. Is betnosol better? Is Dexa better? So let us see what is recommended is both drugs are good and other steroids are metabolized by placental enzyme, and that's why they are not recommended. Now coming to the choice of drug, which is better. So in India, actually beta-methazone, sodium phosphate and acetate, it's a very good combination. But unfortunately, we do not have that acetate. And without acetate, beta-methazone, sodium phosphate becomes a short-acting drug. Therefore, dexamethasone is actually preferred. And the dose for both is the same, that is 24 milligram. In dexamethasone, we know we give 4 doses, 6 mg, 12 hours apart. And beta-methazone, if it is a long-acting, that is beta-methazone phosphate acetate, if it's long-acting, then you can give 2 doses, 24 hours apart of 12 mg. So whatever it is, the dose for both is 24 mg. And the reason we prefer Dexa over beta-methazone is the simple reason that the acetate salt is no longer available with us. So when is the maximum benefit? You give steroid to the mother and you hope that it helps. So what do they say? It is 48 hours after the first dose and 24 hours after the second dose. What about people who deliver immediately? You give the dose and in few hours she delivers. So yes, it will give some kind of benefit, and the maximum effect is from 24 hours after the second dose up till 7 days. They also say that dexamethasone decreases IVH, whereas beta-methazone reduces the RDS. What about the repeated weekly doses? People from my generation would remember, as students, we would be told that, remember this particular day. This is a day you have to give steroid to the patient, and if you miss that day, suppose it was every Tuesday and you miss that day, then the registrar would blast, and it's like you have been negligent about something. But that concept has evolved. Weekly steroid dose is not to be given, and more than 3 doses per pregnancy are not to be given. What really happens if you give repeated weekly doses, where first of all there's delay in the growth, there's a brain developmental delay, lung developmental delay, the adrenal gland insufficiency, maternal neonatal sepsis, placental infarction, and so on. So repeated steroid dose are not to be given. Also, they could be associated maternal hyperglycemia, maternal increase in the WBC count is also there. And in babies, for the fetus and the newborn baby, there is reduced birth weight, behavioral disorders, psychiatric and behavioral disorders, and of course neonatal hypoglycemia. So repeated antenatal corticosteroids are not to be given. So I would like to emphasize on this again and again. What are the patients in which it's contraindicated? Where who are immunosuppressant or suppressed, or who have fungal infection or tuberculosis, sepsis, that may exacerbate with steroids. And fetal heart rate changes also happen as soon as you give a steroid. You may have seen in your practice, suddenly there's fetal bradycardia or change in the fetal heart rate. But this is transient and it picks up again. What about the special circumstances? What about GDM? Wherever indicated, yes, you should give the steroid, and the mother's sugar should be managed with extra insulin, or monitoring of the mother's sugar should be done. What about PROM or PPROM? PPROM, if there's an imminent delivery within next 7 days, then yes, you should be giving. Unless there's frank chorioamnionitis, then it is not recommended. What about FGR at risk? Yes, they should be given if there's a risk of premature delivery. Multiple gestation. We have a lot of ART consultants, and there are a lot of multiple gestations going on. So is it recommended that we give weekly steroid? The answer is no. Multiple gestation should be treated the same way like singleton pregnancy, and steroids should be given only when indicated and only when the delivery is imminent within the next 7 days. What about 22 to 22.6 weeks? Like I spoke about, the lamellar body is not formed, the surfactant cannot be stored, but still there are some parents who want you to salvage their babies. In such cases, detailed discussion should be done with the parents, even if the baby survives, the long-term morbidity, and all these things should be discussed before going ahead with such a thing. So all guidelines recommend that this should be given between 24 to 33.6, and if you give beyond 34 weeks of pregnancy, then there is a potential of long-term harm, and giving steroids after 34 weeks of pregnancy is truly controversial. So this is the changing concept. What about prior to elective section? Few years ago, we were told, FIGO had released that statement that yes, all elective sections before 39 weeks of pregnancy should be given steroid. Today, the concept has changed, and it is by all other guidelines, RCOG, NICE, ACOG, WHO says that for elective section between 37 to 39 weeks, please do not give steroids. What about rescue, salvage, booster dose? Where again there is little bit of controversy here regarding booster dose. RCOG NICE guidelines do not recommend. WHO, yes, does recommend if the last dose was administered more than 7 days ago, and ACOG says if the last dose was administered more than 14 days ago, and when it was administered, the pregnancy was less than 26 weeks of pregnancy. So how about multiple doses of steroids? Multiple doses of steroids leads to, as we discuss, leads to lot of morbidity later on in the offspring. So more doses of steroids, higher will be the morbidity. It is related inversely to the number of courses. So when you give a rescue course, you need to be very, very careful, and more than 3 doses is not really recommended. There are many, many important trials. To mention a few, there's a Aztecs trial where behavioral, educational, respiratory outcome for antenatal betamethasone for term cesarean section. And this was the trial which actually propagated and said, yes, you can go ahead and give and there will be benefit. But most of the trial, this is a huge trial which was conducted between this was conducted in Finland, 1st January 2006 to 31st December 2017, and they have said that there was significant association with mental and behavioral disorders in children who have been exposed to maternal antenatal corticosteroids. There's also a ALP study, and that has also said when steroids were given in the late preterm period, there was associated decrease in neonatal morbidity, and need for surfactant was definitely less. So these are all conflicting studies, and there was a huge WHO action trial where we had to be stopped in between because of the conflicting data that was coming. But the underlying statement is it's very important to use the steroids in a judicial way and not use wherever indicated, and indications indeed are very few, because the more steroid you give, more is going to be the damage. Also, when you give antenatal corticosteroids to the mother, we really don't know how much is going to the baby. And they have said in the sheep model, 1 mg per ml is what is required in the blood stream. That is the concentration at which it is going to help. And we really don't know if this concentration is reached in the fetus when we give it to a mother. And sometimes the baby is already mature. Baby may be 33, 34 weeks, but baby is already mature and may not require the steroids. So there should be a time, maybe there should be ways to identify and treat only pregnancies that will benefit, because otherwise the subsequent sequelae and the side effects and the behavioral changes for the offspring, for the baby, are much more. So to summarize, steroids are recommended between 24 to 34 completed weeks of pregnancy. After 34 weeks, it is controversial. Repeat dose should not go more than 7 days. For elective section, absolutely not. Which steroid right now, dexamethasone, and indiscriminate use leads to potential harm, and that is the reason repeat dose no. 24 to 34 weeks, yes. 34 to 36 weeks may be controversial. After 37 weeks, no. So that is the take-home message that I want to give. And all of us have taken the Hippocrates oath. And to quote him, primum non nocere, that is, first do no harm. So with this, I end my talk, and I appeal to you all. Yes. Thank you very much. I seek your support and blessings for the post of Vice President Foxy, election year 2025, so that I get an opportunity to work with none other than our dynamic leader, Dr. Milind Shah. And I have been chairperson Perinatology Committee for 3 years. I have been working with Foxy since past 20 years, and I promise you I would like to continue working. So thank you very much once again.
Thank you, madam, and all the best to you. You have explained nicely all the aspects of antenatal corticosteroids and a judicial use of it, and not to just administer to every patient. Thank you.
The next talk will be Dr. Anirudh Badade. Topic is ductus venosus things need to learn. Yesterday we have heard him. He's a very good speaker. He is Director Chikitsa Diagnostic and Ultrasound Training Center, Mumbai, which has trained over 4,000 postgraduate doctors in ultrasonography and is recognized as a leading training center in India author of several papers in indexed international and national journals, faculty in several national and international ultrasound conferences and workshops, assistant honorary radiologist Rajwadi Municipal Hospital, ex-honorary radiologist Naurozji Wadia Maternity Hospital, Parel, Mumbai. Over to you, sir.
Thank you for the kind introduction. It's been a great pleasure at Solapur, and SOGS is one of a kind. I've never seen such team spirit, and I'm really happy to have come here, and I thank Dr. Milind and Dr. Monica for inviting me here. The topic is ductus venosus, things we learn, things we need to learn. Now, so far as ductus is concerned, there are various considerations during the pregnancy. One is it has a role in first trimester aneuploidy screening, assessment of congenital heart disease, risk of heart disease in the first trimester, for diagnosis of ductus venosus agenesis, role in fetal growth restriction to optimally time delivery in the early onset fetal growth restriction, role in supraventricular tachycardias, role in twin-twin transfusion syndrome, role in congenital heart disease, and role in non-immune fetal hydrops fetalis. So ductus venosus plays a role in all these clinical situations. As we know, ductus venosus is the terminal portion of the umbilical vein between the IVC and the left branch of the portal vein. It is funnel shaped, it is conical. 45% of the blood from the umbilical vein passes through the ductus venosus. Now, the diameter at the entry site into the IVC is 1/3 the diameter of the umbilical vein. So the cross-sectional area is 1/9 of the umbilical vein. And so there is acceleration of blood, and that causes a high-speed stream of oxygenated blood that goes along the posterior wall of the IVC into the left atrium and then to the brain. And because it's a high-speed stream, the ductus is identified. Here you can see the umbilical vein, and this terminal portion has got bright colors, it has got mixed colors, and it is narrow. So the ductus is identified by these ultrasound characteristics. And here you can see the ductus. You don't have mixed colors, you don't have aliasing, but you have bright colors. This bright spot, this is the ductus venosus. So then, the role of ductus venosus in the first trimester aneuploidy screening, all of us know that the ultrasound markers used for detection of aneuploidy in first trimester are NT, nasal bone, ductus venosus, tricuspid regurgitation, and fetal heart rate. And ductus venosus, high PI in the ductus venosus and reversed A wave will increase the chances of aneuploidy. Technique of ductus venosus in first trimester, all of us know, 11 to 14 weeks, CRL 45 to 84, fetus should not be moving. Magnification should be such that the thorax and abdomen occupy the whole screen. And then you have a mid-sagittal view of the fetal trunk. That means you put it in the mid-sagittal view and put the color on and angulate slightly to the right side, and you'll be able to see the in color Doppler. You'll be able to see the umbilical vein. The terminal portion is got bright colors. That's the ductus venosus and the heart. And then we should use a small sample gate, about 0.5 to 1 millimeter. The filter should be set low. The wall filter is a value that you will find here. You can see here 60. Okay, the wall filter, there's a button called wall filter. So you have to set it low, and the sweep speed should be high, which means you should have 3 to 6 waveforms here. What is sweep speed? You can see this is going slowly across, and so you have too many waveforms out here. But if you increase the sweep speed, it will go across fast, and you can have, and it should be set so that you have only 3 to 6 waveforms. So then, and sometimes you may have to use TVS in order to get the ductus venosus. Now, so far as, now here you can see reversal of the A wave, which is on the other side of the baseline. But what is important to understand is that there should be, in order to call it reversal, there should be a clear gap here. You can see that there is no spectral trace here. There has to be a clear gap here. Again, there has to be a clear gap here. Only then we can call it reversal of the A wave. This is the normal ductus waveform. You can see that there is no gap here, okay, but there is a gap here, and only if this gap is there, then we call it a reversal. Here there is reversal of the A wave, but this is not reversal of the A wave because there is no gap here, and this is due to combined tracing of the ductus venosus, which is normal, and the contamination from hepatic vein. So this is not a reversal. You need to have a clear gap in order to call it a reversed A wave. Now, ductus venosus PI, which is higher than 95th centile, becomes increases the chances of aneuploidy. So deepening of the A wave which is going, which is getting deeper, or A wave which touches the baseline or is reversed, all these increase the chance of aneuploidy, and that is because the value of PI, the value of PI becomes more than 95th centile when you have these findings. And when you have a reversed A wave, we know that it causes increased risk for chromosomal anomalies, cardiac defects, and fetal death. But we must remember that a reversed A wave is found in about 4% of normal fetuses. And when you have a reversed A wave, in 80% of the cases, the pregnancy outcome is actually normal. Then we come to ductus venosus agenesis. Now, in this first trimester fetus, you can see this is the head end and this is the tail end. This is the umbilical vein which is entering, and the umbilical vein is going directly to the hepatic veins which enter into the right atrium, and you can see the IVC separately here as this red structure. So there is no ductus venosus, which would have been a vascular segment between the umbilical vein and the IVC that is missing. So this is ductus venosus which is absent, agenesis of ductus venosus in the first trimester. A similar case here, you can see the umbilical vein entering here goes to the hepatic vein. In red you have the IVC here, so there's no connecting strip here. So this is again ductal agenesis in the first trimester. If you see this section of AC, this is an AC section. Can you find any abnormality here? This is the stomach, this is the vascular structure here, this is the spine here. This is a normal AC section for comparison. Can you find any difference here? Now you can see this is the stomach, and this vascular segment is the umbilical vein, which continues as the left branch of the portal vein, and it curves away from the stomach. Here you can see the vascular segment is curving towards the stomach, and so this is PRUV, persistent right umbilical vein. Now, though it is typically an isolated anomaly, it may be associated with other anomalies. We need to do an anomaly scan, proper anomaly scan, when we have this finding. But in particular, PRU is associated with congenital absence of ductus venosus, and there are two types of PRUVs. One is intrahepatic because the umbilical vein has joined some vascular segment within the liver, and here you can see in this case of intrahepatic PRUV, there is no ductus venosus. The umbilical vein has come here, this is the IVC, this is the aorta. In between you expect a vascular segment here, which is the ductus venosus, that is absent. So it's easy to miss absent ductus venosus in a case of PRV unless you really look for it. And then there is something called an extrahepatic PRU, which is less common, in which the umbilical vein comes and goes directly into the right atrium, here. And then again, naturally, there is absent ductus venosus here. And extrahepatic PRUV with absent ductus venosus is associated with cardiac failure. You can see there is cardiomegaly, and this heart is a failing heart. If you put Doppler, you will find tricuspid regurgitation. Now, in this normal view of the normal bicaval view, this is the IVC, right atrium, and this is the SVC. But in this case, you can see the SVC, in this bicaval view, the IVC is very dilated. This is the right atrium and this is the SVC. So what is the cause for dilatation of this IVC? You can see here that these two are the these two are the umbilical arteries going towards the iliac vessels. And what is this extra vessel here? This is the umbilical vein. So this is the umbilical vein which is going and joining the left iliac artery. And so all that blood from the umbilical vein is going through the IVC, causing dilatation of the IVC here. So this is again ductal agenesis, in which the umbilical vein has drained into the left branch of the left iliac vein. Now, what is the technique to obtain ductus venosus waveforms in the second and third trimester? First trimester we saw. In the second trimester, though many of you might know, I'll quickly cover. You can see it in the axial view, or you can see it in the sagittal view. In the axial view, go to the AC section, put the color on, angulate your probe slightly to the head of the fetus, and you'll be able to see this bright colors you'll be able to see, which may have mixed colors also, and this segment which courses towards the IVC, and that is the ductus venosus. And in the sagittal, in mid-sagittal view, put the color on, angulate slightly to the right side, and you can see the entire extent of the umbilical vein. Terminal portion is got mixed colors or bright colors, and that is the ductus venosus. And this is another example of a ductus venosus with aliasing, and a narrow segment can be identified. Right. Now, what is the mechanism of D wave waveforms? We all know the upstroke is the S wave, which is caused due to ventricular systole, which pulls the AV ring down and causes suction in the atrial, in the right atrium, and so there is forward flow of blood through the venous segments. And then the later part of the systole is the isometric relaxation phase, where the AV ring is going up, but AV valves are not open up. So that is responsible for the V wave, SV. And then the ventricular systole starts with opening of the AV valves, which causes this upstroke of D. And then the new cardiac cycle will start with onset of the atrial systole, which causes this dip here. So we have S, V, D, and A. So you can see that the ventricular systole comprises of A, S wave, and the V wave, and the ventricular diastole comprises of the D and the A waves. Now, the ductus venosus has the highest forward velocities in the venous system, and there is antegrade flow throughout the entire cardiac cycle, and velocities are around 50 to 70 in systolic and about 30 to 60 diastolic, depending upon the gestational age. What we need to understand, very important, is that the ductus venosus waveform correlates with the forward function of the heart. If the heart is pumping properly in the forward direction, then the ductus waveform is going to be normal. And if it does not pump, if the heart does not pump forward properly the blood, then the ductus waveform is going to be abnormal. And this is, so the ductus venosus waveform is of central importance in assessing the overall severity of any cardiovascular pathology. So, a role of ductus venosus in first trimester screening for congenital heart disease. You know that first trimester screening is a bit challenging, and the screening parameters in the first trimester that we use are NT, tricuspid valve, ductus venosus PI greater than 95th centile, and what is called as the AS ratio, which gives you a detection rate of around 60% at 5% false positive. Now, if you integrate ductus venosus Doppler along with NT into the first trimester, then you can, we have an increased prediction of CHD. In chromosomally normal fetuses, where NT is increased and there is reversal of ductus A wave, then you will have identified 83% of fetuses with major CHD in the first trimester. Now, types of waveforms which are abnormal in the first trimester, which will indicate possibility of a CHD, congenital heart disease, in order of increasing severity. It is the A wave reversal. Here you have A wave reversal, but the V wave is truncated. It is less in height. And then here you have a V wave which is touching the baseline. Here the D wave is truncated. Here the V wave is touching the baseline. So these are abnormal waveforms which indicate presence of CHD in the first trimester. Now, when there is congenital heart disease, now these are normal waveforms, and as I said, the waveforms will become abnormal when the forward function is compromised. And then this happens especially in right-sided congenital heart diseases with obstructive lesions such as tricuspid regurgitation, tricuspid or pulmonary valve stenosis and atresias. So these in particular will produce abnormal ductus waveforms, and when we have abnormal ductus waveforms, it should alert us to the possibility of heart disease. In the second trimester, various waveforms may indicate this presence of heart disease. Absent, this is an A wave which is touching the baseline or a reversal of A wave. Here you have an A wave which is large and a D wave which is truncated. You can have M-shaped waveforms. You can have waveforms like this. So when you have waveform, there are several mechanisms for all these. We don't have time to go into the mechanisms of these waveforms. So when you have these waveforms, we have to look for heart disease. In this case of atrial bigeminy, you can see the ventricular rate is only half of the atrial rate, and you have abnormal ductus venosus waveforms because the V wave is less in depth and the D wave is reduced in height. Now, and in the case of tricuspid regurgitation, now this is a normal Doppler waveform, normal Doppler appearance of four-chamber view. The blue is the inflow into the filling of the ventricles, and the red is the aorta, the LVOT. And you can see here, so this is the left side, this is the right side. This is the mitral valve, this is the tricuspid. Okay, here in the normal you don't have any tricuspid regurgitation. Here you can see you have color flowing across the tricuspid valve when the aorta is filling. Both the blue comes at the same time. So this is tricuspid regurgitation, and on spectral you can see velocities are very high, up to 240. So when you have tricuspid regurgitation, there is flow, there is extra blood in the right atrium, and therefore you will get abnormal ductus venosus waveforms in tricuspid regurgitation. So whenever there's a cardiac condition, you have abnormal ductus wave, you might find abnormal ductus waveforms. Now, so though abnormal ductus waveforms are found when there is cardiac dysfunction, but based on the abnormal waveforms, we cannot identify the exact pathophysiological mechanism involved or the exact cardiac anomaly involved. So you know there's something, but you can't exactly predict it based on the waveform. But ductus venosus waveform can be used to monitor deterioration in cases of congenital heart disease. This is, for that purpose, you will require a baseline ductus venosus waveform, and that can be used for future comparison. So if there's a deterioration, it can tell you that the CHD the condition is deteriorating. Now, role in fetal growth restriction. We know that in fetal growth, in early onset FGR, the fetus is hypoxic, the heart is in a hypoxic environment, it is pumping against high resistance in the placenta and in the vasoconstricted body of the fetus. So it's pumping in a hypoxic environment against increased resistance, and that causes the heart to get tired. So it's going to get decompensated and may lead to heart failure. These are late cardiovascular changes, and this is manifest as an abnormal ductus venosus waveform. All of us know that. And then also there is a good correlation of abnormal ductus venosus waveform with late stage acidemia. So because the ductus venosus waveform indicates cardiac decompensation and late stage acidemia, it is used to time delivery in early onset FGR. And so between 26 and 32 weeks, we use ductus venosus to time the delivery, the optimal time of delivery. And ductus venosus abnormality in these situations precedes CTG abnormality, and ductus venosus is abnormal about 2 to 3 days prior to biophysical profile abnormalities. Then the role of ductus venosus in non-immune hydrops. Common etiologies of non-immune hydrops could be structural cardiac malformations, fetal arrhythmias, then pulmonary masses, twin, TTTS, infections. So all these are causes of non-immune hydrops. And many of the conditions that cause non-immune hydrops actually affect the forward function of the heart, and therefore have a ductus venosus abnormality. And we know that ductus venosus abnormality is strongly related to fetal death, and so ductus venosus Doppler should be performed to monitor fetuses in all cases of fetal hydrops. Role in supraventricular tachycardia. In supraventricular tachycardias, you have rapid heart rate, so the function is ineffective. There is pooling of blood in the heart, and so there is decreased cardiac output and increased central venous pressure and hydrops. So abnormal venous, so in a case of SVT, abnormal ductus venosus Doppler will indicate a risk for hydrops, and when you have abnormal ductus venosus Doppler during SVTs, then it is an indication that early maternal antiarrhythmic therapy should be initiated. And having initiated that antiarrhythmic therapy, you can also monitor its response to the therapy by assessing normalization of the ductus venosus waveforms, which happens prior to the cardioversion. Role in TTTS. Monochorionic pregnancies may be complicated by twin-twin transfusion syndrome, and in the first trimester, discordance of ductus venosus also contributes to the risk of developing TTTS in the second trimester. We know the recipient twin has got high output failure, and so that will cause ductus venosus abnormality, and the donor twin may have fetal growth restriction, which will contribute to myocardial dysfunction and therefore again lead to ductus venosus abnormalities. And we know that in Quinteros stage 3 of TTTS, Doppler abnormalities are characteristic, and you can have absent or reversed diastolic A wave. In the donor twin, you have a waveform that looks like this, M-shaped pattern, which is due to abnormal ventricular relaxation, and in the recipient twin you have a pattern like this where there is reversal of the A wave. Following fetoscopic laser surgery, you can monitor the response to therapy. In the recipient fetus, the hypervolemia has gone away, and so ductus venosus PI is going to reduce, and in the donor twin it will develop hypervolemia, so there will be a deterioration in the ductus venosus PI, which typically regresses within around 4 weeks. So you can see that ductus venosus has several roles to play during pregnancy. Thank you for a patient hearing.
Thank you, sir. That was an extensive talk. You have covered all the intricacies of the ductus venosus and beautiful images and videos. Thank you so much.
We request Dr. Meena Gunzotikar madam to felicitate Dr. Anirudh Badade sir. We request Dr. Milincha sir, Dr. Ghate madam to join for the felicitation. We request Dr. Bakul madam, Nanda madam to join for the felicitation. I request Dr. Bakul madam to felicitate Dr. Vaishali madam. I request President Dr. Milincha sir and Dr. Ghate madam to felicitate our chairpersons, Dr. Nanda Magay madam. Dr. Bakul Jagidar madam. Dr. Meena Gunzotikar madam. Thank you everyone.